I would like to welcome everyone to the first webinar of the Tobacco Prevention and Control Program Disparities Webinar Series. This series of webinars is going to focus on local tobacco prevention control efforts that engage and support populations in Wisconsin that are disproportionately impacted by tobacco. We hope that these webinars will be in collaboration, or these webinars are going to be in collaboration with the Center for Disease Control and Prevention's national networks, who are focused on preventing and controlling tobacco-related cancers in special populations. And if you, when I sent out this webinar announcement, there was a link to that initiative from CDC, where you can access all of the national networks. So this CDC approach supports a consortium of national organizations to advance the prevention of commercial tobacco use and cancer in populations experiencing tobacco or cancer-related health disparities. So a webinar today features Edgar Mendez from the Wisconsin Tobacco Prevention and Poverty Network, Lorraine Lathen, the director of the Wisconsin Tobacco Prevention and Poverty Network and the Wisconsin African American Tobacco Prevention Network, and Dee Calhoun, director of the SelfMade Health Network. Edgar will be sharing results from the Milwaukee Tobacco Retailer Density Study. Lorraine is going to be sharing results from a smoke-free multi-unit housing survey that was done in Milwaukee. And Dee is going to provide information about the SelfMade Health Network, including resources and technical assistance available to local coalitions and networks. So we are going to begin with Edgar. Edgar, go ahead.
Good morning, everyone, and thank you for being here today. As Karen mentioned, my name is Edgar Mendez. I'm the coordinator of the Wisconsin Tobacco Prevention and Poverty Network, and I'm pleased to be here this morning to share with you some of the very preliminary findings from our tobacco retailer density study. You can go ahead to the next slide, please. But before I go into that, I want to talk a little bit about the mission of the Poverty Network, and that is to reduce tobacco disparities experienced by low socioeconomic status populations through community engagement and education and other strategies. Next slide, please. As far as this TRD study, it was largely prompted by what we were learning in the Wisconsin Retailer Assessment Project, or the WRAP study. As many of you know, that study was piloted in Milwaukee in 2016 before going statewide. And what we did in Milwaukee was focus on three specific clusters in Milwaukee. One was largely African American, one was largely Hispanic, and the third cluster was largely white and suburban. And you can go to the next slide, please. And some of the things that we found, aside from higher rates of advertising of menthol and more candy being placed near tobacco products in Hispanic and African American neighborhoods, was that we found that there was also higher tobacco retailer density, or there was 1.5 tobacco retailers per 1,000 people in African American neighborhoods, 1.4 in Hispanic neighborhoods versus these suburbs. So looking at that prompted us to look deeper into issues related to tobacco retailer density. So what is TRD and why is it important? So tobacco retailer density refers to the amount of tobacco retailers in a specific geographic area in relation to the population. Why is it important? Well, many studies have shown that the higher the tobacco retailer density, the higher the smoking rate in the area, and also the higher youth initiation and exposure rate to tobacco. If you look at this image right here, it's not in Milwaukee, but it's very common. It's something that you'll see in the central city, and that's a public elementary school within very close proximity, and in this case, right across the street from a tobacco retailer. Next slide, please. So there are certain strategies to reduce tobacco retailer density. These ones were provided by our friends at Counter Tools, and one of those strategies is to cap the number of tobacco retailers within a specific geographic area. So, for example, maybe 15 or 20 per zip code, something like that. You can also cap the number of retailers relative to population size. So say no more than one tobacco retailer per 1,000 or 2,000 residents in a specific area. You can require a minimum distance between tobacco retailers, for example, 500 or 1,000 feet. You can also prohibit retailers from locating near schools or other use-sensitive areas. Another example of a strategy to reduce density is to prohibit sales of tobacco products at pharmacies or other types of retailers. One example of that was in New York City, where they banned the sale of tobacco products at pharmacies and also big box stores that house pharmacies. As far as the specific impact of that policy, I don't think it had, from what we heard from our partners, it didn't have the impact it could have had, because in the areas that had the higher tobacco retailer density, those just happened to be the areas that didn't have as many pharmacies. So they had more corner stores and gas stations that people were purchasing their tobacco from. Next slide, please. So how has TRD been addressed elsewhere? I mentioned New York City, but if you look on the right, that's Madison. And what Madison did was implement a zoning ordinance that prohibited new tobacco retailers from opening within 500 feet of an existing tobacco retailer or within 1,000 feet of a school, playground, youth center, or park. Looking at the left, that's Sonoma, California. They did something similar to Madison in banning new tobacco retailers within 1,000 feet of schools, and also prevented the issue of new tobacco retailer licenses if the density in the area is already higher than one tobacco retailer per 2,000 residents. They also instituted a policy that will revoke the licenses of retailers with multiple violations for selling tobacco to minors. Next slide, please. As far as going back to our survey, the purpose of our survey was to better understand community awareness and support for tobacco retailer density regulation. Next slide, please. So when we created the survey, our goal was to collect 600 surveys by the end of November. So far, we've collected 509 since May. And where were they collected? Well, they were collected at a variety of locations. We collected surveys at a number of Milwaukee public libraries. We collected surveys at many community events, back to school fairs, the Fatherhood Summit, the Medical College of Wisconsin's Cancer Crush event, many occasions where it was celebrations. So if you look at the bottom right, that picture is from the NAACP barbecue. We collected surveys at Juneteenth. So a variety of locations within the city. Next slide. And what are some of our preliminary findings? Well, there are some good news. 75% of respondents supported limiting the number of tobacco retailers in Milwaukee's central city. Another thing that we found was that there was strong support for local control of tobacco policies and laws. So one of the questions we asked respondents was what level of government they thought should have the primary control over tobacco laws, and we asked whether it should be local, state, or federal, or a combination of them, and we're finding strong support for local control. We also asked those who supported limiting the number of tobacco retailers, who should do that work? So who should work to limit the number of tobacco retailers? And we offered them a number of options, including local and state leaders, health departments, tobacco prevention groups, residents, and we found that they've supported a diverse group to work together to limit the number of tobacco retailers. The only group that we had listed that had a little bit less support was law enforcement, and I think there were several reasons for that, including that people were just saying that the law enforcement, the police just already had enough to do. So we can go to the next slide. So not all the news was great. We had some discouraging preliminary findings, although maybe not surprising to residents of the city of Milwaukee. But 75% of respondents reported tobacco retailers within 2 blocks of their nearest school, park, or youth organization. We also found that 40% of respondents reported more than 5 tobacco retailers near their home. And 69% of respondents reported that the nearest tobacco retailer was within 1 to 2 blocks of their home. Now, once we do further analysis, we can look deeper into that answer, because another question that we asked was whether people believe that having a tobacco retailer near their home would makes it harder for a smoker to quit, or for someone to quit using tobacco. Can we go to the next slide? So kind of based on that, we one thing we need to do is to complete our data collection. So we have about 100 more surveys to collect this month, and also complete a data analysis. I just mentioned one example of something that we could look at using a crosstab, but we also want to look at whether current and former smokers support limiting the number of tobacco retailers. And surprisingly, for myself, having collected probably 200 surveys, it did seem that even current and former smokers supported limiting the number of tobacco retailers. But we'll be able to look at that more closely once we analyze the data. We're also going to be able to look at specific zip codes and also break down statistics by race and other factors. We'd like to present the findings and develop a peer review article for publication. That's something similar to what the Milwaukee area groups did with the Zilber School of Public Health and the RAP findings. We'd like to submit abstracts to Wisconsin Public Health Association, National Conference on Tobacco or Health, and other conferences to share what we've learned in other locations. Not included in this list, but probably most important, is reporting back our findings to the community in the form of a community event or something like that. We know anybody who does community-based participatory research knows that it is extremely vital to take back the information to the communities in which you collected it. And not just that, but involve residents and let them take leadership roles in developing a plan to address the findings of that research. Next. Well, we're going to save the questions for the end, so we can just go to contact information. And I want to thank everyone for being on the call today. And hand off to Karen.
All right, thank you, Edgar. Great job. The preliminary findings you shared are definitely interesting, and they attest to the importance of the work that you are doing there to raise awareness about retailer density. And I just want to let everyone know that we are planning to expand this effort around retailer density, and we are working with Edgar to develop some more resources, which will eventually be put into some sort of toolkit and provided on TOBWIS. So before we move to Lorraine, I just, like Edgar said, just a reminder to put any questions that you have in the chat box, and we will address those later. And next up is Lorraine Lathen, the Director of the Wisconsin Tobacco Prevention and Poverty Network and the Wisconsin African American Tobacco Prevention Network, to talk about results from a Milwaukee multi-unit housing survey. Go ahead, Lorraine.
Great, thank you, and thank you for everyone who has joined us. Today I'm going to share some results from a survey that was conducted between April and August of 2019, and it was, next slide please. And I have to recognize a number of people. Dr. Bruce Christensen from C-Tree, he certainly helped with the data analysis, and we worked very closely with the Housing Authority as well as a number of public health or public housing residents that were our data collectors, and funded in part through American Lung Association. Next. These are all of our partners. At different times they came and helped. Before the HUD policy went into effect, a year prior to that, we worked with the health department in offering freedom from smoking, because we did not want our residents to risk eviction because of a tobacco addiction. And that we also collaborated with American Lung to offer freedom from smoking. And then Hyatt Pharmacy offered pharmacists on site for Q&A, where residents were able to ask questions on how quit aids might interact with other drugs that they were taking, or prescribed drugs that they were taking. Next, all of our work certainly has been done focusing on tobacco disparities. Quite a few of the populations that we work with certainly fall within the group that you're seeing here that are dealing with tobacco in ways much higher than other parts of the population. Next slide. And as I mentioned, our data collectors, they were public health residents. They went through about 20 hours of training. We trained 9 of them, and I'd say 5, they stuck with us to the very end and continue to work with us. Next. We also had the help of AHEC, Milwaukee AHEC. So we had med students and public health students, and then we also had our fact youth that helped collect the data. Next. Just a little bit of background about Milwaukee. Again, most of you probably already know this. Milwaukee is the largest city in Wisconsin, but the 5th most impoverished. So you're seeing people at higher rates living in public housing. The Housing Authority for Milwaukee is the largest in the state. They provide services for about over 10,000 families. They've been providing these services for 75 years plus. And they have housing developments, 19 of them. We sampled 18 of the 19, and then they have what they call scattered sites, where it's individual housing that's offered through public housing. Next, please. The design, our public housing residents, they helped us design the survey. We pre-tested it with them. We collected 574 surveys. They were closed-ended questions. We used tablets to collect the information, and it took about 6 to 10 minutes to complete, and with 94% completion rate. Next. We did have challenges. The challenges were around technology. Because we were using tablets, we needed internet. We were told that there was internet in public housing. That was not always the case, so we ended up having to use a mobile modem. And then the budget was very small. We had about a $4,000 budget, and most of that money was used for incentives and also to pay our data collectors. Also, we had problems reaching a younger audience. We had older residents that participated in the survey. Next, please. This is just some examples of where the data was collected in the community. We were very creative. Next slide. In terms of incentives, we followed the Pick and Save food truck around the city, and we set up shop when the food truck would arrive, and we would offer activities for the kids and food. At the top, you see a couple dressed in all white. That was an all-white party that was held. All white meaning you wear all white clothes. And in order to do that, we served as the photographer. So we came in and took the pictures, and we surveyed people before they went to the party. The dollar store was our friend. We used the dollar store to buy lots of household cleaning products that were given away as incentives. Next. So what we were really interested in learning was whether or not, what were the residents' perceptions of the policy? Was it effective, a smoke-free policy? And then also we wanted to have more of an idea of what they felt their needs were moving forward after, like, post-implementation of the policy. Next. I mentioned a little bit about the demographics, an older population, predominantly African American, in terms some high school graduation, and then we had a pretty good split in terms of current smokers or never smoked, and then we had also some that had mobility issues. Again, we're talking a much older population. So next slide. What we found around knowledge is that people are very knowledgeable of the policy, but there's about 25% of them that still need more information. And the biggest areas of confusion were around e-cigarettes. They did not realize that e-cigarettes was included in the policy, as well as whether or not you could or couldn't smoke on your private patios and balconies. And then also, they didn't realize that the nicotine patch is not included in the policy, nor is chewing tobacco. So there's still room for education. Next slide. Enforcement, for the most part, people felt that the policy was being enforced just about right. Next slide. And they thought it was being enforced fairly as well, for the most part. Next. And then whether or not it was effective, you're looking at the pink color is before the policy and then after the policy. We wanted to gauge whether or not they felt that they're smelling less or more smoke after the policy had been implemented. And basically 1 in 5 residents are still reporting smelling some smoke, but clearly there's a decline in the amount of smoke that they smelled after the policy took effect. And that was smoke coming in their homes from the outside. Next slide, please. The attitudes about whether or not the policy was fair, again, it's kind of very polarized. Normally when you do any type of survey, you'll have a lot of movement kind of in the middle, but you see either people strongly agree that the policy is fair or they strongly disagree. Next slide. And that's also as it relates to smoking space should be more comfortable and better protected from weather. So we were trying to get at whether or not, since you have to go 25 feet from the building, what was the attitude? Should there be a shelter there? Should there be more protection? And again, smokers as well as non-smokers felt that there should be more protection provided. And also they talked a little, people would offer up the issue of security as being an issue as well if they had to go out to smoke. Next slide. And then what we did find out, and we were happy, is about 80% of all people who smoked that they reported quitting. They reported taking one positive behavior towards quitting. Either they tried to quit, they reduced the amount of smoking, or they went to see a physician. So we were really excited. When you get 80% of the people trying to quit, that's something to kind of do a happy dance around. Next slide. And then we're trying to look at what was the type of support that they felt they needed. And those are listed, the top 3 types of support. They wanted on-site support groups, they wanted incentives to help quit, and they wanted on-site cessation. So we really, in terms of the on-site cessation, that's something that we're trying to work with to make sure that that happens. Most of the residents had Medicaid or Medicare, so they had a way to pay for cessation, but they just didn't want to leave the building. And then also, I think they appreciated the support that they got from other residents by taking the freedom from smoking in a residential setting with other residents. Next slide. And so there was that small group that they're not going to change. It's about 20%, I would say, of the total sample size, no matter what. So these were some of their comments, that when we asked the question, what type of help do you need from housing authority, they said that they didn't want help, they wanted to let me smoke, they don't, or the housing authority can't help them, not ready to quit. Nothing can be done until they're ready. I can quit on my own with God's help, mind their own business in terms of referring to public housing or to housing authority. And that was about 20% of the population. Next. And so when we look at people that had issues related to mobility, whether they were using walkers or wheelchairs. For the most part, their perceptions were just about the same. And I didn't present, we did lots of crosstabs. I didn't present those today. If anyone's interested, please reach out to me. But they pretty much agreed with everyone else around the issue of smoking space as well. They strongly agreed that it should be more comfortable and that they should be protected from the weather. But for the most part, their responses were aligned with people that did not have mobility challenges as well. Next slide. And so just to summarize, as I mentioned, knowledge is high. There's some areas where we need to focus on, and that's for just a minority, about 25% of the residents. Most people do believe that that the policy has been effective in reducing smoking in public housing, and that it's fair and appropriate. And as I mentioned earlier, there's that polarization of attitudes, either on certain issues where they either strongly agree or strongly disagree. So I think that's something that management, the resident managers are going to have to be mindful of as they're working with their residents. And then also we know that the policy has motivated behavior change in a positive direction, with about 80% of all smokers taking a step to quit. And as I mentioned, there's that 20% that there's no matter what you do, they're very resistant to the policy and will most likely remain resistant. This last one was really surprising to me, that smokers of lower education are more likely to take action than smokers of higher education. So normally when you're dealing in public health, it's like your higher the education is, the more prevention you're taking. But in this situation, lower education, they were more willing to try to quit and or reduce their smoking. So that is kind of the research that we've done, and I guess what I share with you is that this is the only research that has been done in the United States. So we're pretty excited and proud of that. Next slide. And so these are our next steps. We shared this information at our quarterly meeting, and the Housing Authority did attend that meeting. We recognized those residents that helped us collect the data, our data collectors. We'll be sharing the findings with the leadership of Housing Authority as well as residents. We are in the process of finalizing a peer review article for publication. And then this is the one that really excites me. Everything's exciting about this, but the fact that we're trying to find support through other means, of other avenues, perhaps the hospital system, or even med students, nursing students, pharmaceutical students that could help provide on-site cessation. So we're trying to identify that partnership and then resources to provide incentives for people who are wanting to quit. So I thank you. I think next slide is probably questions, which we're holding as well. And the next slide is my contact information, I believe. And so with that, I think I'll turn it back over to Karen. And yeah, thank you.
All right. Thank you, Lorraine. That was excellent. I think you also are doing some great work around that. And while the HUD policy has been very effective, there's clearly more education to be done. And we'll figure out, what the next steps are. So thank you for sharing. Okay. Next, I am thrilled to introduce Dee Calhoun, who is the director of the SelfMade Health Network. The SelfMade Health Network focuses on populations with low socioeconomic characteristics and works to enhance the capacity, quality, and performance of state tobacco prevention and cancer control programs to advance best and promising practices to respond to the unique needs of low socioeconomic status populations. So once we get her slides ready, then Dee will start. While we're waiting, Lorraine, I did have one question, and maybe we can, I'll ask you this while we're waiting for the slides to get started, but you mentioned that some of the properties that are part of the Milwaukee Housing Authority are scattered homes. And are those public? Are they public housing, so they fall under the HUD rule?
Yes. Okay. So they're family units.
Yeah. And did you do any cross-tabs with, like, responses from the people who lived in those or anything like that?
We didn't, because the sample size was so small.
Okay.
But the one thing that's interesting I didn't mention is that we collected 574 surveys, which was actually 15, it represents 15% of the total residential population that is impacted by the HUD rule.
Okay.
Yeah. So that was, because it's around 3,000 something that are impacted. So that's a really good representation.
Sure. Cool, thank you. Okay, so I think we are ready for Dee. Dee, if you want to start, go ahead.
For SelfMade Health. Thanks again for the invitation. I am Dee Calhoun, National Network Director for SelfMade Health Network. We are a member of the CDC's Consortium of National Networks, who were established in late 2015, and I actually assumed this role in late 2015 as well, after transitioning from a state government position. But as our national network focuses on vulnerable populations, we strive to reduce cancer and tobacco-related disparities among populations with lower socioeconomic status characteristics. Next slide, please. And this includes low-income workers or workers with an annual income that is at or near the federal poverty level, as well as populations residing in medically underserved areas, populations with lower levels of educational attainment, as well as populations who are uninsured, underinsured, or unemployed. And in addition, we are supported by a National Leadership Council that is comprised of 13 members, representative of various organizations that function in an advisory role. Thank you. Next slide, please. Third, National Network's collaborative work in breast cancer and lung cancer disparities has been presented at various national conferences, including the American Association for Cancer Research Conference on Cancer Health Disparities in Racial or Ethnic Minorities, as well as the medically underserved. Our work has also been presented at the CDC's National Cancer Conference, as well as the CDC's National Conference on Tobacco or Health this year and in 2017. And then last year, our work was also featured at the American Public Health Association Annual Conference. Next slide, please. Okay, thank you. So shown above is just a snapshot of some of our work that was presented at the CDC's National Conference on Tobacco or Health that focused on tobacco-related cancer disparities. And that work included our grantees in Michigan, Iowa, as well as Pennsylvania. And then also our work that focuses on men's health in Kentucky was also featured at this year's NCOH conference. Next slide, please. So a few examples of support that we provided to state government programs, and their partners have included states such as Nebraska, Illinois, Vermont, and also in collaboration with one of our national sibling network partners, GEA, we presented at their mid-year institute in Nevada, where they invited programs and coalitions from states nationwide. Next slide, please. Thank you. We have also provided support to states such as Virginia, where we served as the official state cancer plan reviewer and presented along with other with academic institutions and cancer centers at their various events. We've also provided support to state government programs and their partners in South Dakota, as well as Mississippi, which is not shown, where we provided technical assistance, one-on-one technical assistance guidance that led to the development of an RFP that focuses on tobacco-related disparities. Next slide, please. Thank you. And we've also provided technical assistance to West Virginia. So shown above is just a snapshot of our support that we provided as part of their lung cancer conference, which was hosted by one of our leadership council members, the West Virginia Cancer Institute. And in reference to additional services that we provide in reference to state programs, to coalitions, to other types of organizations, our services can be kind of categorized into a couple of general areas, including strategic planning, community clinical linkages, as well as healthcare system strategies. But we also participate in providing feedback as part of health equity reviews. And then shown above is just one example of recommendations that we provided to the American College of Surgeons in response to their revision of their Commission on Cancer accreditation standards. And the recommendations that we submitted were in various sections, including healthcare quality improvement, health equity, and public health, and all from a perspective of lower socioeconomic status characteristics populations. Sorry about that. We also provide technical support to various types of organizations as they are developing or tailoring their communication materials, including fact sheets. And so we do co-brand with coalitions as well. And a member of our leadership council is a member of the National Colorectal Cancer Roundtable's efforts as they continue to improve colorectal cancer screenings throughout communities nationwide, including populations that are at risk for tobacco-related cancer disparities as well. Next slide, please. And to further support the needs and interests of organizations, we host a series of webinars from our Opening Door webinar series on various topics related to cancer and tobacco-related disparities. Next slide, please. And that includes tobacco-related cancer disparities as it relates to rural health, men's health, also the attainment of becoming a certified tobacco treatment specialist, and then also webinars that focus on subpopulations. So for example, featured here is just one of the webinars that we hosted to focus on vulnerable Asian populations, including Korean, Vietnamese populations as well. Additional topics that we have posted and webinars that we have topics that we've hosted as part of our webinar series includes not only breast cancer and colorectal cancer disparities, but more extensive information about addressing lung cancer disparities. So what you see here is just one of those topics regarding closing the gaps in lung cancer disparities, and our host was an oncologist from Harvard Medical School. And we also recently hosted a webinar that focused on the delivery of tobacco cessation interventions in rural health clinics. And the audience varies. It also includes just rural health practitioners. And this particular webinar was hosted and included presenters from a quality improvement organization as well as a primary care physician in South Carolina. And then we also focus on access to care issues. So we did have a presenter from CMS, the Centers for Medicaid and Medicare, as part of our webinar. And all of our webinars include supplemental attachments that can be downloaded for use, whether you're planning, implementing, or evaluating your activities. We also develop fact sheets as part of our services to organizations and state programs nationwide. So shown in the previous slide was just an image of our determinants of health fact sheets, and that includes topics, and those topics that we have addressed include smoking among working adults, smoking and poverty, how smoking impacts illness, and that includes addressing COPD, of course, men's cancer health disparities. And then we've also launched what was called a Healthier Nation Fact Sheet Series in collaboration with one of our national network partners. And access to those fact sheets is available. You're just welcome to contact me directly. But the good news about our Healthier Nation fact sheets is that it was also featured in Trust for America's Health, Wellness and Digest, Wellness and Prevention Digest, and shared with its 9,000 Twitter followers. And it focused in various areas, including cancer screening, cancer survivorship in the workplace, as well as tobacco cessation among cancer survivors. And the audience for the Healthier Nation fact sheets includes our labor unions, small business associations, chambers of commerce, minority-owned businesses, as well as state programs and their partners who are working with blue-collar industries and are trying to reach low-income employees. And so the next few slides just kind of feature some images from our national Healthier Nation fact sheet. So that's one image. And then on the next slide, you see another image. And on the next slide, you'll see another image, because we want to ensure that we reach not only the rural population, but our urban or metropolitan populations as well, because they're all a part of medically underserved areas. And to connect with us, to join us, to follow us, to learn more information about us, you all are welcome to not only visit our website, but we're pretty active on Twitter as well. So we have 2 Twitter handles. We have our main Twitter handle, and then my little personal handle as the National Network Director. We recently launched a new Facebook page and a quarterly newsletter that is available to all member organizations and state programs. We can be contacted at any time. And I mentioned that we're pretty active on social media, so we wanted to kind of just provide you with just a few examples of some of our social media followers, at least from my little handle on Twitter. So they include the National Cancer Institute, the National Rural Health Association, the CDC's MMWR follows us, American Academy of Pediatricians, the Tennessee Hospital Association, Oklahoma State University Center for Rural Health, the Public Law Center, Iowa Cancer Coalition. And then on the last slide, we have examples of more Twitter followers. That includes the Community Preventive Services Task Force, of course, the National Association of County and City Health Officials, America's Essential Hospitals, the COPD Foundation, Iowa's Community Action Association. We were excited to have them on board. Indiana Small and Rural Schools Association, Tobacco Free Louisiana, as well as Arkansas Center for Health Improvement. And there are other organizations from various sectors that also kind of follow us, and we're really excited about that. And I think that kind of concludes our just kind of general presentation about our network. But thanks again for inviting us to provide you all with information about SelfMade Health Network. Thanks.
All right, thank you so much, Dee, for being on the webinar today. And thank you also to Edgar and Lorraine for being on the webinar. The presentations were wonderful, and I think you all shared great information. We have a good amount of time left, and so I haven't seen any questions come up in the chat box, but if anyone has any questions, we will just take the next minute to see if questions appear, and we'll take some time to answer those. If not, like I said earlier, we do plan to make this sort of a series of webinars to eventually address all of the populations that are included in the CDC national networks that are focused on preventing and controlling tobacco-related cancers in special populations. Next, oh, it looks like we have a question. So Angela asked, Lorraine, were multi-unit housing residents involved in the design planning of smoking outside areas? Any recommendations on that based on lessons learned or best practices?
So Angela, the residents were involved in the actual development of the HUD implementation plan for the city of Milwaukee. There were conversations, small group discussions that occurred throughout the year, and they were able to provide input and also to speak at a public hearing. So they made recommendations, and Housing Authority, if you don't realize this, the HUD ruling did not come attached with any budget, any funding. So public housing around the United States were required to implement this through their own budgets. Milwaukee Housing made the decision that they did not have funding to do anything as it relates to the outdoor smoking areas. So that's still under discussion, and that's something that we will be reporting back to their leadership to say that this is something that's coming out of the research that we'd like to help them revisit and maybe find some funding to help with the smoking areas. So they were involved, but they weren't successful in getting it included in the implementation plan. Thank you.
All right, great question. So as I was saying, we do plan to have more of these webinars, and next we have a webinar planned for December 4th, and I will be sending out information on that webinar. The topic area will be African Americans, and Lorraine will be back with us.
I will. I have a question for, okay, so I have a question for Dee, or two questions. Dee, can you tell us a little bit about how you work with grantees? I didn't realize that the CDC networks actually had grantees. And then how can states or individuals request TA through your organization?
Oh, good question. Two questions. So one, regarding how do we work with grantees, we are not selective in reference to what types of organizations we provide support to. So any type of organization, company, coalition can just email us directly and request assistance if they're not sure about what specific type of TA they need or training they need. We usually set up an introductory call, and we kind of help guide them through the process until we kind of help them to identify what their needs are so that we can meet their needs. And then we also, throughout the year, post RFPs or release RFPs, and that is how a number of states were able to receive funding through our national network.
That's exciting. I didn't realize that. That's very good to know. Thank you.
Oh, you're welcome.
Yeah, and I think if any coalitions or networks are interested in technical assistance, reaching out to you is a great idea, and then also, working with your contract administrator, and we can make sure that just to connect with you on that TA request. So we do have another question, and it says, my question is, can coalition members listen in, or is this a specific tool for coordinators? Yes, you can share this with any coalition members. Anyone is invited to listen in on these webinars. Great question. All right, I see no more questions. Thank you everyone for being on this first webinar. I will be sending out later today the link to this recorded webinar. So you all have that, and then I will be sending out a email and calendar invite for the next webinar, which is planned for Wednesday, December 4th at the same time. All right, everyone have a great day. Thank you.